All righty. Hello, abnormal students. How's everybody doing? Plan for today is to start childhood disorders. We will finish up the childhood disorders next class, and you will have your third exam after that. So that's kind of where we're at right now. So let's go ahead and cruise through. When we start thinking about risk factors for psychological disorders in children, we tend to be thinking both biological kind of nurture and nature nurture at the same time. So let's first talk a little bit about gender as a risk factor. Because women have XX chromosomes and men have XY chromosomes. For women, if there's a problem on any of the chromosomes on one of the X's, it can be counterbalanced by the other X chromosome. But for guys, if there's an error somewhere on either their X or their Y, they're going to evidence that genetic error. So when we start thinking about childhood psychological disorders, we see boys are more at risk than little girls. Okay. And then that tends to shift around the teen years and around puberty, where we start to see girls start to evidence more disorders, more depression, more anxiety, more eating disorders, that type of thing. Other biological risks would be things like in utero risks. So if mom smoked, used drugs, had prescription drugs that were toxic, anything like that, was if the baby was delivered quite prematurely, things like that would be some of those other biological factors that are not necessarily genetic. But then keep in mind, the epigenetics talks about how whatever genetics somebody has inherited, depending on the environment, so even the uterine environment, certain genes could be turned on or turned off that. So again, clear interaction between nature and nurture. Psychosocial risk factors would be things like does this child have a loving parent or loving parents or loving guardians? It could be things like, is that child well nourished? When you think about little babies, babies come into this world around about 7.5 pounds. And if you take a look at a newborn versus a 1-year-old, there is more head growth and more brain growth that occurs during that first year of life. So imagine if that child is poorly nourished, as well as if parents or guardians are not stimulating the child, so holding the child, playing with the child, all of those kinds of things. So you've got both the biology of the nourishment, and then you've got the interactions, the neuronal interactions of that child interacting with other people, and engaging in play and things like that. So there's a lot going on in that first year of life. So any questions here when we start talking about risk factors for childhood disorders? Okay. Okay, so the first disorder that we're going to talk about is autism spectrum disorder. And so now it's called ASD or spectrum, whereas we used to have different kind of categories in where Asperger's was considered to be the highest functioning form of autism. And then there were lower functioning forms of autism. And now we kind of think about this as being more on an entire spectrum. So that's why it's called autism spectrum disorder. The word autism means self. And the reason why it was given this name is that early on, individuals, particularly physicians, scientists, who saw this, it seemed like these individuals were locked into themselves and not very interested in social interaction, like most children and even newborns are interested in. Okay. It was discovered by Eugene Bleuler back in 1906. And autism spectrum disorder is considered to be a pervasive developmental disorder. And what this means, and even in the DSM, we used to put this on axis 2, which is where we put personality disorders, because remember, we kind of conceptualize the personality disorders as being more permanent than, say, the axis 1 disorders like social phobia or depression, that type of thing. So axis 2 meaning it's going to be more permanent. So pervasive developmental disorder, once it gets diagnosed, because an individual has this, they're going to have it all of their lives. It is 1 out of about 152 children get a diagnosis of ASD. And this is 3.5 times more common in boys than in girls. And if you all have not seen the movie Rain Man with Dustin Hoffman, also Tom Cruise, it is a fantastic movie about an adult Raymond who's Rain Man. Dustin Hoffman plays just a really good job of older individual with autism. Okay. Okay, we've got a lot of DSM criteria here, so I'm going to try to walk us through it. And then what I would like for you all to do in your study strategy is make sure you kind of keep these in their clusters so you're able to memorize more of these big A, B, C kind of things here. So first, there are deficits in social communication and social interaction across multiple contexts. And keep in mind, babies that are neurotypical, that do not have this, from the get-go, babies know how to lock eye contact, interact. I remember my younger son, he spit up a lot, so I always had a diaper cloth with me whenever I was holding him. And it wasn't until one day he told me he was ready to play peekaboo. So instead of me playing peekaboo with him, he had the diaper cloth on his face and he would yank it down and then he'd laugh when he'd see my face. And then he'd put the diaper cloth back up and he'd pull it down. And it was one of those like, oh, Forrest is ready for peekaboo. Like, you know, he told me that kind of thing. These individuals have deficits there. There's not that kind of interaction going on. So there tends to be deficits in that social emotional reciprocity. And again, little babies that are neurotypical, that do not have this, get very excited when they see a human face. When my boys were little, my youngest would watch my older son just do anything, and he thought it was hilarious. You know, it was just that, you know, just watching, interacting, and that emotional kind of thing. There tend to be deficits in nonverbal communication. So normal kids, way before they have language, are gesturing. They know how to point. They know how to, my friend has I guess he's about, she's about 7 months old now. He's learning how to wave. Like that's his thing. It's like he sees somebody and he does the hand and then he says bye-bye and he does the hand. These children would have deficits in that nonverbal. And then there would be deficits in developing, maintaining, and understanding relationships. So this is the one where that term autism self, you really kind of see it. There's the lack of the social interaction in a lot of different ways. Okay, let me exit this. I'm going to show you a clip here of twins who do not have autism. And what I just want you paying attention to is their verbal and their nonverbal interaction. And what you will see is there's something going on about a missing sock. Okay. So these are children without autism. And I want you just to pay attention to their communication. Okay. So obviously they did not know many words, right? I mean, they're just like their whole language was dead at, right? But they were going back and forth, taking turns in talking, and then there was something humorous going on. Could anybody figure out what the funny thing was?
Was it the leg that they were doing? Like they kept lifting the leg. I don't know if that
Yeah.
was.
So one of the little dudes had on 2 socks, and one of the little dude only had on 1 sock, and he kept lifting the leg without the sock. And there was something, I mean, I don't, anybody have a guess, but there was something funny about that. Like maybe they're sort of figuring out like, hey, I got it right and you don't have it right in some way. So yeah, I mean, and it's kind of infectious when you hear them giggling like that. You could see how they were engaging one another, and how easily neurotypical, like these little dudes, how they could get adults engaging with them, or getting other children engaging with them, because they obviously had pretty normal communication and interpersonal skills even well before they had language. Okay, so B, so we've talked about A, which are those social deficits. B is restrictive, repetitive patterns of behavior, interests, or activities. So as an example, a friend of mine has raised a son with autism spectrum disorder. And when he was little, he would go through these phases where there were very specific things when I would visit him that he would want to talk about. So it wasn't like, broad range, it was very restrictive. So you get oftentimes these stereotypical repetitive motor movements. And so at times it could be, say, children kind of shaking their hands. When I worked in a camp, when I was an undergrad, a summer camp, and we had some kids with ASD, there was one little boy where whenever he would disappear, we would find him in the bathroom. And what he loved to do was run the sink water and run his hands over and over and over through the spout. Like that was his thing. He really enjoyed that. So repetitive motor movements, using objects or speech. A lot of times there's repetitive speech. If you all saw the movie Rain Man, one of the things that Rain Man liked to do, particularly when he was stressed, is he would do this old comedian skit, Who's on First? And he would repeat over and over again the who's on first. So that in that situation, it's repetitive speech. Insistence on sameness and flexible adherence to routines. Kids like ritual. I can tell you, kids like schedule, kids like predictability, kids like ritual, but children with autism spectrum disorder are very rigid about the ritual. And so they tend to be pretty inflexible. So I worked with a female client who was a mom of a child with ASD at one point, and she talked about how the tuck-in routine for her son, that was very specific, but before she would turn off the light and close his bedroom door, she would have to say, I love you very, very, very much. And then he would be fine and go to sleep. But if she were to say, turn off the light and go, I love you very much, and shut the door, he would have a meltdown. So it was very important for her to sequence and follow the exact type of routine. Okay. Highly restrictive, kind of fixated interests that are abnormal intensity or focus. So I want to give you an example. If I were to take a neurotypical little kids and give them, say, a fire engine to play with, what would they do? What would a kid without this do with the fire engine? Everything my little guys did when they were little, they did it loudly. Everything was loud. Okay. So if they got the fire engine, my bet would be they would be rolling that fire engine around, making the fire engine sound, right? Woo, 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 that kind of thing. Okay. A child with autism might take the fire engine, flip it over, and go like this to one of the wheels and be fascinated with the spinning of the wheel. Does that make some sense? So even with kind of the restriction in play behavior, you might see some of that difference. Symptoms have to be present early in development, and pediatricians and parents in general, and even preschool teachers, if children are in preschool, have all gotten better at identifying when they suspect that particularly a infant or preschooler might have ASD. So it's got to be present early in development, again, because this is a pervasive developmental disorder. So having it all throughout their lifespan, it's got to create significant impairment. And this should not be explained, whatever we're seeing in this child, these deficits, should not be explained by just intellectual disability, okay, which would be lower IQ. Okay, so I'm going to stop share here and let me go to our polling. So causes. What causes autism spectrum disorder? Let's see what you've got here. You got it. You all are wise. You were wise well before this class. Yeah, brain dysfunction or neuroatypical is one way of kind of conceptualizing this. But I can tell you historically, there has been a lot of thoughts about poor parenting. And we're going to talk about refrigerator parents here in a bit. There was a lot of talk about diet. Although some of these children are very sensitive to gluten, and caretakers and parents have to be very careful about making sure that they don't get gluten in their diet. And then you all, I think you know this, that there are a lot of individuals that believe that vaccines cause autism, and there's absolutely no scientific evidence about that. And interestingly, the anti-vaxxers nowadays are also many of the individuals that, should we get a coronavirus vaccine, are also the individuals who are saying that they would refuse to get that vaccine. Okay, if we get a vaccine coming out, we need to make sure that we've got something that is safe for us. Okay. Okay. So we'll get to the refrigerator pants here in a second. Okay, so one of the earliest physicians that were seeing this were oftentimes brought in by parents who were well educated, and oftentimes parents who were well to do. And what the physicians were observing in the parents' interactions was this kind of weird thing where he deemed this, he started calling it refrigerator parents. And so it'd be the idea, like if I had a neurotypical infant and I was interacting with that infant, they would be making eye contact. I would probably be not just holding them, like you might be if you're nursing. I'd probably be standing them up. I would be doing kinds of things, moving their arms and legs, and really just interacting with that child. The refrigerator parents thing kind of happened because they would have these parents holding these children, but these children would be like, let's say I had a ceiling fan going on. Instead of wanting to make eye contact with whoever's holding them, they might be more interested in the ceiling fan that's spinning around. But it looked like these parents were cold. Okay, there wasn't warm, fuzzy, humorous interactions going on between parents and child. It looked more custodial, like, they're taking care of the child's physical needs, but they're not those interactions. Nowadays, we know that is generated by the child with ASD. So it's not the parents, it's the child's behavior, and then the parents are responding accordingly. Okay. There seems to be quite a bit of genetic heritability. About 90% of ASD is heritable, which means about 10% is something else. So maybe it's interuterine environment, turning on some stuff, turning on or turning off genes. Lovaas's observation was that in that wrap up of self, that oftentimes individuals with ASD get easily overstimulated, and that is accurate. Okay. And so Lovaas was thinking that these individuals can only take in one piece of stimuli at a time. And that kind of fits in. We're going to talk a little bit later about applied behavior analysis, where we are training one type of behavior or skill, one at a time, trying to shape behavior in individuals with ASD. If you have seen Rain Man, there is a scene in Rain Man that is rememberable, but for a true person with ASD, absolutely ridiculous. There's a scene where Tom Cruise, the brother, the younger brother of Rain Man, realizes that Rain Man's got these splinter skills, and he's got this incredible ability to count numbers and to actually, there's a scene where toothpicks fall on the floor, and Rain Man's like 297, and then he like just sees the pile of toothpicks and he's got them counted. And the waitress realizes, she looks in the box and it was like a box of 300 toothpicks. She looks in the box and there are 3 stuck in there. So it was like this incredible ability to be able to do numbers. So anyways, Tom Cruise takes Rain Man to Las Vegas, and there's a scene where they're in their tuxedos and they're looking all dapper and they're coming down the escalator into the casino. But I don't know about y'all, if you've ever been to a casino, and I can manage a lot of stimuli, but I find casinos to be overstimulating. There's like ding, 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 and there's lights and there's people, and it's just like, whoa, and there's music playing. There's a lot going on in the casino. There is no way in real life Rain Man, if he had ASD, could have handled that casino atmosphere. So Hollywood didn't get it right on that one. All right. So applied behavior analysis, and this is kind of born out of when we talked about behaviorism, we talked about classical conditioning, we talked about operant conditioning. Applied behavioral analysis is going to operate on that. And there's going to be a lot of ABCs, like what are the antecedents or the stimuli for behavior, B meaning the behavior, and the C's would be the consequences of the behavior. So antecedents, behavior, consequences, ABCs. And in ABA, they're doing that, where they're really trying to shape behavior over time. So as an example, somebody doing ABA, let's say, who's trying to teach a person with ASD to, when they come into the room, make eye contact, say hello, and then maybe, let's say, if this is a parent or a caretaker, even give a hug. And so let's say they're using Cheerios. Okay, they're using Cheerios as the primary positive reinforcer. If that kid likes Cheerios, and it would be like, let's say this little boy's named Johnny, and I walk into the room and I go, hello, Johnny, make eye contact, Johnny. As soon as Johnny looks me in the eye, he gets a Cheerio that he gets to eat. And then it'd be like, you say hello to me, Johnny. And once Johnny's able to make eye contact, say hello to me, he gets another Cheerio. And then it might be, I would like a hug, Johnny. Can we hug? And then there would be sort of arms around and squeeze. And every little bit of that kind of behavior, where ideally you walk into the room, hello, Johnny. Johnny looks at you, hello, mommy. I would like a hug. Okay. And there's that kind of sequencing. Does that make some sense? So it's, I don't want to use the word tedious, but there's a lot going on to be able to shape that behavior. Does that make some sense? And keep in mind that ABA has gotten a bad rap over the years because every now and then they will use punishers. But for the most part, people who practice ABA use a tremendous amount of reinforcement to shape behavior in individuals with ASD. The punishers only come into play where, and again, an appropriate way of punishing a child nowadays would be timeout, and a timeout procedure. But keep in mind, kids with ASD could go sit in timeout and be by themselves. And a lot of times that's not punishing for them. Okay. The aversives punishers, the positive punishment is only used when children are self-injuring. So if I've got a kid with ASD who likes to bang their head on the wall, then, and I say, stop banging your head on the wall, and they keep banging their head on the wall, one of the positive punishers that might be used in a situation like that could be Johnny, and pinch their skin. Johnny, stop pinching skin, stop hitting your head on the wall. Or it could be, sometimes they do this in these intensive programs, it could be a spray bottle of water, so nothing toxic. And if Johnny's banging head on wall, go up to Johnny, Johnny, stop banging your head on the wall. He keeps banging his head on the wall, squirt in the face. And Johnny's like, ooh. But because of that squirt in the face, and again, it's just a spray of water, it's not going to hurt him, interrupts the behavior of banging the head. Okay, so what I want you all to know, there's lots and lots of reinforcers used. Every now and then punishers are used, but they're only used when there is injurious kind of behavior, unsafe behavior that could be creating more harm than, say, the pinch on the skin or the spray of water in the face. Any questions about that? I don't know if you all have heard of some of the history of that, but there's some politics behind the bad reputation there. Okay. Medication wise, we do not have any meds that really treat autism. So when medications are used, they're usually used to treat other diagnoses that are going on. If there are dramatic temper tantrums or if there are aggressive behavior, there are times where the antipsychotics are used that provide a tranquilizing effect. The ABA people would say, if you're seeing a tantrum or aggression, you need to know what the antecedents and the stimuli are in that environment. And you need to know what the consequences of that aggression or tantrums are, because a lot of times there's something that will stimulate that behavior, particularly frustration, something frustrating. And then if the consequence is the kid gets what he or she wants out of the tantrum or the aggression, then that kid has been reinforced. Okay, so the ABA people would say we should not be prescribing this stuff. We should be shaping their behavior in the environment. Okay. I had, when I was on my internship and I was doing a consult liaison service, we rounded on this family that had this older, their older son had ASD and some intellectual disability. And he would have a meltdown every evening close to sundown. And we call that sundowning. It's a real thing that you see in compromised people with pervasive development disabilities, head injuries, nursing homes, that kind of thing. And I remember I was surrounded by all these psychiatrists, and they really wanted to sedate this adult man every evening to prevent him from doing this. And we were able to get in there and realize the frustration was when the sun would go down, parents wouldn't turn the lights on inside. This adult didn't know how to do it. The ASD person didn't know how to do it. And what he wanted were lights on and a little bit of stimulation going on in the environment. Okay. Sometimes stimulants are used for like attention deficit kind of things. But again, you would have to see that overlying like ADHD type of thing, but nothing that's really actually treating the actual autism. Okay. I felt like I missed something. Yeah, let me go back. Oh, here it is, case examples. Okay, I'll go forward and exit this. Before we go on to intellectual disabilities, I've got another clip that I want to show you. If I can find it. Okay.
Catherine Muir. I have Asperger's syndrome.
Me llamo Catherine Muir.
Ich heiße Catherine Muir.
Tengo el autismo.
Und ich habe Autismus.
J'ai l'autisme.
Autism doesn't really change the person, just slightly the way they think.
I'm currently a college student majoring in photography, but when I transferred to the University of Tennessee, which I have been accepted to this fall, I will be majoring in humanities and photography.
It also cuts into the communication and makes it hard for them to communicate with some people, such as I.
We have a real hard time reading social cues. We have a real hard time looking people in the eye. I always look at the bridge of the nose.
It gets in the way of my thoughts. It gets in the way of learning. It gets in the way of having friends, and it gets in the way of having fun.
One of the good things about it, that like you think in a different way than other people. And being different's okay.
The positive thing about living with autism is the unique perspective I have and use in my nature photography. I am often told I see what others miss.
The honesty that can come from someone on the spectrum can be quite beautiful.
Autism affects my reading, writing, and sometimes it's hard for me to start off or continue on a conversation with others. But if it's an activity that catches my interest, such as sports, music, video games, etc., I stay focused. Sometimes I learn certain skills faster than others.
For me, it tells me that I learn a certain way. On my free time, I mean, I go out and I DJ at raves and parties, and you would never expect anybody with Asperger's syndrome to say that.
I tell others about autism, and I give demonstrations at my school. I tell governors, senators, and even presidential candidates. And one day, hopefully, I'll get to tell the president about autism. And right now, I am telling all of you.
Autism cannot and will not stop me.
Don't judge me before you know me.
Okay, so there you saw quite a few individuals with different levels of intellectual ability talk about their autism, and there was you kind of got to feel there was an eagerness to kind of try to help individuals who would be neurotypical without ASD understand what it's like. You know, these individuals oftentimes like, I want you to understand what it's like to be me. So any questions about autism spectrum disorder before we move on? Okay. Intellectual disability is the new name in the DSM. We used to call this mental retardation. And now the term mental retardation is considered to be offensive. Okay. So intellectual disability. And this is where there are deficits in intellectual functions. So this would be deficits in ability to reason, to problem solve, to plan, to engage in abstract thinking, to engage in judgment or academic learning. And the way that this diagnosis is made is there is standardized IQ testing, as well as clinical assessment. And most child psychologists, when they do these assessments and they do these diagnoses, they will oftentimes do a variety of different things. This is the same for autism as well here. They will oftentimes interview parents or guardians. They will observe the child, sometimes observe the child at home, observe the child at school. They will oftentimes do the standardized testing. And then let me move ahead here, and then have parents, guardians, and teachers fill out a scale that is called the Vineland. And the Vineland looks at this child's functional behavior. Okay. So I remember I had school psych graduate students doing the Vineland on me when my sons were little. I can tell you psychologist kids get tested to death. You know, they just get tested over and over and over because the school psych students, the clinical students, they need children to test. And so we volunteer up our kids. But one of the questions I remember on the Vineland, them asking me, and I think my kids were something like 2 and 4 at the time. And one of the questions was, do you allow them to cook open flame on the stove? And it was like, no, she said, can they cook on open flame on the stove? And it's like, I don't know, maybe they could, but I wouldn't let them. That would not be appropriate for a 2 and a 4-year-old. Does that make some sense? And so it's really asking about their ability to engage in personal independence. So cooking on an open flame and on a stove would probably be appropriate for an 18-plus-year-old kind of thing, okay? And then also looking at deficits or failures in social responsibility. And so the way these two are normed, individuals have to have, and let me see if I've got this on the next slide. Now, let me go back. For standardized IQ testing, a standard deviation in IQ, and you remember that normal bell curve, is 15 points, okay? And average IQ is 100, okay? So college students tend to fall 100 to 100 and like typically about 115, but anywhere range from like 100 to 2 standard deviations, which would be 130. Genius starts at 145 as an example. So we would go in the other direction, 2 standard deviations below the norm. So that would take us down to 70 or lower in IQ. And then the Vineland is normed exactly the same way. Based on the child's gender and the child's age, average would be 100. Okay. And so there would need to be, if there are deficits here, a Vineland score of less than 70 for an intellectual disability diagnosis. Does that make sense? Okay. And the age of onset has to be before the age of 18. But obviously, this is a pervasive developmental disorder. We've gotten much better, teachers, pediatricians, parents, at being able to notice when this is evident earlier in age than later in age. But what they're trying to get at here, I don't really see that they need to, but what they're trying to get at here is that you could have intellectual disability later in age, but we just covered that. That's what we call dementia. Right? Dementia or delirium. Okay. So when we look at in our culture today, and we look at the level of IQ and the degrees of severity for intellectual disability, what you're going to see here is that the majority of individuals living with intellectual disability have an IQ and a Vineland functional ability somewhere between 50 and 70, when again, average is 100. Less individuals would fall into the moderate category. Even less would fall into severe intellectual disability, and very rare to have 1 to 2% would be considered to be profoundly intellectually disabled. That would be an IQ and a functional ability below 20. So obviously you're seeing these percentages decrease as IQ goes down. Anybody want to take a guess at what's going on there? I'll give it to you. Oftentimes, especially individuals with profound, but usually individuals with severe and oftentimes with moderate intellectual disability, there is more and more medical disability or genetic disability going on. And so these individuals that would fall in these kind of categories are a lot less likely to survive. Does that make some sense? So one example would be if there's been severe oxygen deprivation in the birthing process. And one of the things obstetricians are very careful about. I had a friend who her obstetrician caught this. Her baby had umbilical cord wrapped around its neck. And if she would have engaged in a normal vaginal delivery, that baby would have likely died. So because her obstetrician picked up on that, she had a C-section and her baby was fine, ended up being fine. So if you had severe oxygen deprivation, or let's say you've got some kind of genetic disease that prevented full physical development in utero, you're likely going to have this severe intellectual disability and not necessarily physically survive. Okay, so that's some of the reason why we've got this. Also note that some individuals with mild intellectual disability, if they had had a healthy in utero environment, a healthy birth, and they had a healthy environment where they were fed well, stimulated, interacted with adults, interacted with other children, some of these individuals would likely have been of average or above average IQ. So sometimes it's the environment that can disable the brain. And I go back to that, those from newborn until 1 year old, it is amazing how much that head grows. You take your kid to the pediatrician, not only do they give vaccines and do an exam, they measure weight, they measure length, and they're always in there measuring that head, making sure that head growth is happening when they are little. Okay. Causes, most of you are probably most familiar with Down syndrome, and with Down syndrome, you've got an abnormality on a third chromosome, the 21st chromosome. And with Down syndrome, you get characteristic physical attributes on the face, particularly a mongoloid type of look in the eyes. And then there's oftentimes a certain body fat pattern for individuals with Down syndrome. And women nowadays, if they're getting good obstetrical care during their pregnancy, there's a blood test that is done at, you've got to be right around 16 weeks of pregnancy. And it's an AFP test. And I had some friends that had some AFP scares. They had some abnormalities in their AFP. And then after the doctor went and did a ultrasound where they measure the fetus's leg. And when you measure the leg, you get an absolute accurate date of gestation. How old is that fetus? And so I had friends that had some scares, mainly because they weren't right at 16 weeks. They get this abnormality, the doctor does the ultrasound, measures the leg, and let's say they're at 20 weeks or they're at 14 weeks, and they're thinking that based on their missed menstrual period, they were at a different place in gestation, as an example. If most women over the age of 35 are oftentimes not only given the blood test, but are oftentimes given some type of genetic screening. So it could be an amnio. There's some other kinds of villa sampling kinds of things that they can do. But the sad thing here is, and I'll even give you an example, at 16 weeks of gestation, most mamas are feeling that baby flutter. Okay, at that point in time, and it's a more organized flutter than, say, feeling gas inside your tummy. When babies start moving around, and they tend to do that at night when you lay down and want to go to sleep. So to have an abnormal AFP at 16 weeks, and then maybe to go and do other genetic testing, then to find out, let's say, that this fetus likely has Down syndrome or might have spina bifida or some other type of genetic anomaly. At that point in time, for mom and partner, that's a tough decision for a lot of individuals. It is not an easy decision to decide if they wish to carry that baby to term and have a child that might have one of these types of conditions. Or the other option is to consider a therapeutic abortion. So tough decisions for couples. I'm so grateful that I never had to do any of that, but I've worked with people who've had to do that. Tay-Sachs disease is a disease that tends to, is genetic in Jewish individuals. The majority, about 32% are these types of genetic causes. Another genetic kind of issue is Fragile X. But then about 12% are prenatal issues, particularly if mom is not well nourished, if she's smoking, using substances, is taking toxic over-the-counter or toxic prescription medications. Those would be some of the prenatal risks. About 8% are trauma or lead poisoning. When I was on my internship, we had in Grand Rounds at one point in time, and this really kind of helped me when I interview individuals and how to screen for interpersonal violence. As an example, I was trained that you do not ask a person with injuries, what happened to you? Because a lot of times they will tell you, oh, I fell down the stairs, or I'm clumsy. I fell on the curb kind of thing in the parking lot. I was trained, and this is much more effective, I can tell you all this, to look a person in the eye and say, who did this to you? Okay. And when you say, who did this to you, you are a lot more likely, if there's interpersonal violence going on, getting the correct answer. I was also trained, and again, I'm not a physician, so I'm not looking at x-rays, that if an individual has injuries that are healing in many different stages, then they are likely a victim of interpersonal violence because they're getting repetitively battered in one way. I remember my pediatrician, when my boys were little and it was winter time, he wanted to see their legs, and he pulls up their their pant legs. And my question was to him, I said, are you looking for abuse? Are you screening for interpersonal violence? And I remember Dr. Horn saying, no, I'm looking for bruises on their legs, because if they don't have bruises on their legs, they're not active enough. And my guys had lots of nice bruises on their legs because they were quite hyperactive as little ones. But anyways, I remember the pediatrician telling me, he said, no, for abuse, we usually get bruises like on the arms where they're being grabbed and they're being shaken. It was like, oh, okay, that's interesting. So anyways, so I've got this physician is doing grand rounds, and he's training us on how to look people in the eye, ask who did this to you. And then he showed us a picture of a ultrasound of a woman whose husband during her pregnancy, and interpersonal violence, interestingly, increases during pregnancy. When it's existing in the household, you tend to see an increase in pregnancy. And then when children are born, you tend to see an increase in a transfer from partner over to children. But the ultrasound that we saw was a fetus with its leg that had a compound fracture, where the husband had hit her in the belly with a baseball bat. Okay. That child was going to be very high risk, okay, because of that blunt trauma to the abdomen and the uterus, as an example. Horrifying kinds of stuff that can happen. Lead poisoning can be an issue. So trauma, lead poisoning, particularly prenatally for individuals. And then the cultural familial piece to it could be, and this is part of the reason why there are programs like Head Start. And I am quite a fan of Head Start, that gives children that are lower in socioeconomic status the opportunity to attend preschool and to get all the wonderful socialization and intellectual stimulation, and learn their ABCs, and learn how to count, and learn their colors, and learn how to say please and thank you, and get along with other children, where by more well-to-do individuals who are able to afford high quality childcare, preschool childcare, those kids are given such an advantage when they get to kindergarten. Kids who have had that, who they've had parents who are interacting with them and teaching them, reading to them, where they're going to preschool and then they're learning, how to clean up after themselves, like please and thank you, all that kind of stuff. Such an advantage when they get to kindergarten versus kids that come from lower SES and do not have that type of interaction. One of my colleagues, Dr. Pam Kidder-Ashley, she's a school psychology professor. And when she was a school psychologist, she tells this story of how she had this little boy who kept getting brought to her office because of misbehavior in the classroom. And he had had such a rough day and he had missed his school bus. So she ends up taking this little fella home. And she talks about how as soon as she got in the car and she buckles him up, he falls asleep. He's exhausted. First of all, he's not getting like normal sleep at home. And then she goes to this poor neighborhood and, knocks on the door, meets mom, and mom invites her inside for coffee or water or something like that. And she decides this is an opportunity for me to actually talk with mom in this child's home about ways of helping him, because he's having such a rough time behaviorally and academically at school. And her observation, I'm going to tear up at this because every time I picture Pam telling this story and tearing up. The mom had a newborn. And the mom kept, I'm going to show you my couch, there's nothing there. The mom kept setting this newborn up on the couch like it was sitting, and the newborn kept falling over. And then the mom would go and place the child and sit the newborn up, and it would fall over. It was like, and it's just, that's so sad. But the mom just didn't know that's not how you place a newborn. Newborns are placed on their back on kind of a soft, flat surface type thing. So it was just kind of that was a mom that was really struggling, did not have the education to sort of know normal development, that type of thing. And then again, that little boy was kind of struggling in school. So sometimes we get those really sad types of stories. But Head Start, the program Head Start, is usually government funded. I'm a big fan of it. And it really does help those children have access to good preschool environment so that they are not behind when they start kindergarten. Can you imagine how tough that would be? And then those are the kids, if they're behind in kindergarten, they keep getting behind. And those are the kids that oftentimes fail grades. And those are the kids that oftentimes drop out of school and do not get a high school education. So you can kind of see how some children have these lifetime trajectories that other children who are blessed and are in better environments do not have those lifetime trajectories. Any questions here? Okay. Let me do another poll. Yep. Oh, I'm not there yet, but let's go ahead and do this. Okay, so we're about to go into ADHD. And I'm curious for you all if you think that ADHD, attention deficit hyperactivity disorder, is overdiagnosed, or is it accurately diagnosed, or is it underdiagnosed? Let's see what you're thinking. Okay. The majority of you are saying that you think it's overdiagnosed. About 8% are you're saying it's accurate, and about 25% of you are saying it is underdiagnosed. So we will take a look at that here in a bit. And my take on that, you're going to hear me really stress this today, is that it depends on how the diagnosis is made. That this is one of the places where I strongly believe, and my colleagues who actually do this testing and assessment, our psychology clinic does this. Psychology clinic is run by Dr. Jackie Hirsch in the psychology department. It's different than the counseling center. Okay, the counseling center does not do testing. It does not do diagnosing. But this type of diagnosing should be done by a qualified psychologist who knows what they're doing. Okay. Pediatricians do a lot of diagnosing. They do not have the skills. They should be referring to psychologists for this. Okay. Okay, so let's start walking through ADHD. So attention deficit hyperactivity disorder. I think your generation knows about this already. Okay. Y'all had opinions about the diagnosing. There are songs about this. There's an alternative song, Blame It on My ADD, as an example. And so let's walk through this, because the way the DSM has created the diagnostic criteria, it's pretty good at, if we do the right type of interviewing and testing and surveying and that type of thing, it's pretty clear when an individual does have this diagnosis, and pretty clear for us when they do not have this diagnosis, that there's something else going on. And again, it's the psychologists who know how to do the testing to figure out the something else going on piece. Okay. So this is where persistent pattern of inattention, that should be or not of, sorry, or hyperactivity impulsivity that interferes with functioning or development. And then they've got a lot of criteria to roll in here. Okay. 6 or more of the following symptoms of inattention have to have persisted for over 6 months. So this is not a temporary thing. It's a continuous thing. Persisted for over 6 months to a degree that is maladaptive and inconsistent with developmental level. And so again, one of the things that the psychologists are going to do is, when they're doing their interviewing, when they're doing their testing, they are always comparing this child, their client child, in age to the norms in that age. So we would never, as an example, say test a 6-year-old kid and compare them to 12-year-old kids, because developmentally, we want to be comparing them to kids on their developmental level. Okay, so here are the descriptions of some of these 6 or more of the following types of inattention. And I think this is going to be intuitive to you all. Often failing to give close attention to details or makes careless mistakes in schoolwork, work, or other activities. Did you all do this? I still remember doing this in the classroom when I was a kid, and I used to get bored a lot. So I talked too much and I got in trouble a lot. But we were given a task where the teacher said, I'm going to give you this. I want you to read the instructions carefully and then start doing the activities. And I did not read the instructions carefully because the instructions carefully said, sit quietly in your seat for the next 15 minutes or something like that. But I jumped like a lot of my little classmates did too. And it was like all this fun stuff to do, like go up and touch a piece of chalk and go back to your seat, twiddle your pencil in the air kind of thing. And the whole classroom was a buzz, of doing all this kind of stuff because the majority of us did not read the instructions carefully. Okay. That was a moment of inattention, as an example. Often having difficulty sustaining attention in tasks or play activities. And I want to pause here and kind of talk about this. All of us, whether we have ADHD or not, can sustain more attention in stuff that we enjoy. Okay, like a video game where we keep getting reinforced and moving up to a cooler level in the video game. Or watching certain shows on Netflix, as an example. All of us can do more attention on the stuff that we enjoy. So we've got to be really careful when we're looking at this for kids, because sometimes kids are not sustaining attention because things are just kind of boring for them. Okay, but then they are capable of sustaining attention when things are more interesting. Often does not seem to listen to when spoken to directly. And what do you think this does to parents? And then we're going to talk a little bit about what this sometimes does to teachers. So let's say it's like Johnny. Johnny doesn't turn and look. Johnny, right? It creates naturally, my dog just like, what? It creates a lot of yelling, unfortunately. And so again, psychologists getting in there, making these diagnoses, oftentimes are going to need to work with parents, work with school system. But again, what could be another reason why a child doesn't listen when spoken to directly besides ADHD? We got any speech therapy students in this class? What if the kid can't hear, right? This is why it's not a good idea. And then this happens all the time where parents go to pediatrician. I think my kid has ADHD. The teachers are complaining. Can I please have stimulant medication? A good assessment is going to take a look at that kind of stuff. If the kid can't hear, you could give the kid Ritalin. It's not going to help them hear any better. Okay. That's not paying attention because of ADHD, as an example. Questions here so far? We're still cranking on inattention. Often does not follow through on instructions or fails to finish work. And my friends who are child psychologists, they say one of the things that they do when they go and observe a kid in a classroom is, well, first of all, they interview and they survey the teacher, but they say that one of the things they like to go do is take a look at their desks. And I don't know if you all had the desk that had the little cubby in it. But oftentimes these are where kids have wads of paper shoved into their desk. They can't find their pencils. It's just a mess, a quote mess. And that's oftentimes kind of a product of ADHD. But failing to finish work. So a lot of times these kids are not making grades that they're even capable of because they're just not finishing stuff or they're not getting it turned in. Often having difficulty organizing tasks or activities. Often avoiding, disliking, or reluctant to engage in tasks that require sustained mental effort. That is hard for all of us, but some of us without ADHD are better at making ourselves do that kind of stuff, and then moving on to more enjoyable stuff afterwards. Often losing things necessary for tasks or activities, forgetting their lunches, not having pencils, not having their paper, not having their calendar or to-do list filled out, those kinds of things. Are often easily distracted by extraneous stimuli. So these are the kids that are out of their seats and looking out the window because there's something much more interesting happening out in the playground than is happening in the classroom, for example, and often forgetful. And so you get a lot of, in these kids, a lot of them going, what? You know, it's that like, what did you say? Like, I was thinking about this, or I was doing this, what? And then you get a lot of, oh, I forgot that. Oh, I forgot that. Okay. So you could see how we're going to talk about the medications here in a little bit, but with a lot of this kind of stuff, you can see that how at home and that how at school, these individuals are going to need a different kind of support. Okay. And diagnosable ADHD, not only may they get some type of medication, but they're going to get a linked up to the special ed teacher, and they're going to get an IEP program and get special support that will help them with a lot of this kind of stuff. Okay. My partner has a bit of ADHD. I think he knows it, but he cannot like get out of the house without coming back in 3 or 4 times, because it's like, oh, my keys, oh, my wallet, I forgot my laptop, you know, it's just that kind of stuff. And I just like, I just let it buzz around me. It's one of those things. I lost my keys once. It was funny because I always keep them in my purse. I've got a place where I keep them, and I lost them once, and I was like, where are my keys? Well, what did I do? And I remember he's like, oh, I'm good at this. I can help you with this, because he's always trying to track down stuff. Okay. 6 or more of the following, now we're moving into past the inattention and we're moving into the hyperactivity. So 6 or more of the following symptoms of hyperactivity that have persisted for 6 or more months, and they have to be maladaptive. Okay. The hyperactivity genetics runs in my side of the family, and both of my sons were quite hyperactive when they were younger. And it was always a yearly type of activity to make sure that their teachers kind of understood them. It was always an ongoing, let's wear them out. They played sports all of their little lives into their teenage years. I used to play a game, particularly in bad weather days, where in bad weather, I'll use my stationary bike or I'll use my treadmill. But when they were little, they were really competitive. And we would play this game called Let's See Who Can Run the Longest and the Fastest on the Treadmill. And again, they were so competitive. So one would get on there and would run for 10 minutes and be like, oh, you can beat your brother. You can go for 15 minutes. And he'd get on there, want to run for 15 minutes. And I would just be sitting by going, yay, yay, wearing them out. Okay. So here would be the symptoms of hyperactivity. Fidgeting with hands or feet, squirming in seats. These are kids that have a really hard time sitting still. I got to tell you this story. I went and I observed Forrest. His kindergarten teacher wanted me to come in and see him in the classroom because she kept complaining about behavior from him. And so I had to go see it for myself. And it was so cute. I go into the classroom that day, and all the little boys that were his friends, they're like, it's Forrest, Mom, it's Forrest, Mom. So it was really sweet to, be like a celebrity in the kindergarten classroom. But there was a point where I was observing them in circle time. And we used to call it, this is politically incorrect nowadays, Indian style. Now they call it crisscross applesauce or something like that. And they're sitting in the circle for a prolonged period of time. And there was a point where the teacher was talking about Paul Revere. And I remember watching my son Forrest, where one of the little boys, like, he couldn't take the sitting any longer, and he pops up out of circle time and he starts galloping around the classroom like he's Paul Revere on the horse. And I'm watching Forrest, and I'm just like, oh, Forrest, don't get up and be a horse, don't do it. And Forrest is trying really, really hard to be good. And then there's a point right after that where the little boy sitting beside Forrest farts really loudly. And at that point, I'm like, Forrest is not going to be able to hold it together. I just know he's not. And he didn't. He could not hold it together. He bursts out laughing, and he's like, he farted and all this kind of stuff. And then I'm like, oh no, here we go. Here's where the meltdown happens. And then it took him forever to recover his behavior and sit back in circle time and behave, kind of thing. And it was just like, oh, here we go. And the teacher's like, see what I'm talking about? So having difficulty remaining seated. There's some symptoms here. These are my favorite in the DSM, the way they're worded. Runs about or climbs excessively. These are kids that are into everything. You gotta secure your house when you've got little ones that are moving about, but boy, you really got to secure your house when you've got these kids, because they can engage in some really dangerous behavior. I remember being on a house site that was being built, and there was scaffolding outside of the house, and I'm up on the second floor looking out the window, and then there was this moment where it was like, oh my gosh, Forrest is dangling on the scaffolding. He's way up high dangling, and it's one of those like as a parent, like, oh my God, like I did not think to hold your hand and keep you with me just because there was scaffolding there. Having difficulty or playing in leisurely activities quietly. These tend to be loud kids. Okay, they tend to be talking a lot and being quite loud. This is my favorite DSM criteria ever. Is often on the go or often acts as if driven by a motor. And these individuals, particularly as children, when their frontal lobe has not developed like we get in early adulthood, will tell you that they feel like they can't stop talking and they can't stop moving, that it takes a tremendous amount of their mental energy to inhibit, to stop that kind of stuff. Okay. And interestingly, for individuals who are on stimulant medication, they will talk about how after they take their medication, usually in the morning, like they're zipping all around, and they take the medication, and then there's like the motor, like there's brakes on that motor kind of thing. Okay. And then the talking excessively. Okay. The sort of sharing every little moment. We used to joke when Forrest was little that he didn't have a thought that he hadn't shared. Like there were never any inside thoughts. They were all shared thoughts. I got to tell you a story real quickly about me trying to relax at one point in time when my kids were young. So they had been read to, whatever, one evening. I'd had a rough day. I go back and I run myself a bubble bath. And keep in mind, when kids are little, they're always in the bathroom with you. Like there's no privacy, and then you're potty training them. So there's all that stuff going on. But anyways, I go back and I get down into the bathtub with the bubbles. And then soon one of my cats is coming. My cat is on the side of the bathtub and is interested in the bubbles. And I'm trying to keep my cat from falling into the bathtub. Then Forrest shows up and he's on the side of the bathtub and he's like, I'm trying to have a Calgon moment. Okay. And then there's Forrest and he's like, and then before I know it, right where my head is in the bathtub, the toilet is beside me. Before I know it, Christian comes in, drops trowel, takes a dump right beside me. It's just like, oh my God, I'm trying to have a mommy moment to myself, and there's a cat, a gibbering child, and now it stinks, right beside me. It was just, oh my goodness. It's amazing they survived into adulthood and I didn't kill them. Okay. Impulsivity. This impulsivity kind of goes along with that hyperactivity. Often blurting out answers before questions have been completed. I used to get in trouble with that in school, and I had many a teacher complain about my boys when they were in the school system for blurting out answers. I made one teacher really upset one time because my response was, I can't remember who she was and who she was complaining about, but she's like, he blurts out answers before I've asked the question. And my response was, did he get the answer right? She did not appreciate that, but part of me sitting here thinking, so you're saying my kid is quick and smart? Is that what you're saying? Yeah. No, she's saying your kid's disrupting the classroom is what she was saying. Okay. Often having difficulty awaiting their turn. So these are the kids that tend to get impatient. These are the kids when they're in line are oftentimes pushing on the kid that's in front of them, that type of thing. And then often interrupting or intruding on others. And so I've been, kind of picking fun at some of this stuff, but some of this stuff here really can interfere with the educational environment for other children. Okay. Particularly if this a child in the classroom is needing constant attention from teachers. My little boys were always seated next to teachers. That's kind of where they were in the classroom. There was no put them in the back and let them go crazy kind of stuff. They really can't interfere with the learning for other children. And then we've got to be careful with a lot of this kind of stuff that it does not turn into antisocial behavior, if that makes some sense. So I've given some kind of innocent examples here, but this can turn into aggression, and it can turn into antisocial controlling behavior if we're not careful. And again, that's why this is the kind of thing that you want a school psychologist involved in, or a child clinical psychologist involved in making the diagnosis and in making recommendations for these kids. Questions here? Okay. I'm going to keep plugging away. We may have a really short and sweet lecture on Tuesday. I'm just kind of watching the time. We've got 5 minutes here. For the diagnosis, there's got to be an onset of symptoms present by age 12. Again, just like the theme that we've talked about all throughout this lecture today, pediatricians have gotten better at suspecting all of these things. There's more like developmental testing that happens in pediatrician checkups for parents who have access to that kind of healthcare. We know that one of the best predictions of a child who has any of these diagnoses getting correctly diagnosed is if mom has a college education. Sorry, future dads, it doesn't matter if dad has a college education, but if mom has a college education, if she has, because of her education level, and you all taking this class, you're going to have this. If she has concerns about her child's behavior or her child's development or what seems like delays in development, she's more likely to take that kid to pediatrician and say, I'm worried about my kid. I would like, and then good pediatrician or nurse at pediatrics office is going to make a referral to school psychologist or child psychologist for that. So we're seeing this stuff a lot earlier. And then point C, I think, is very important. And again, this is why those psychologists are likely to observe child in school, maybe observe child at home, have parent guardian fill out a Connors survey, have teacher fill out a Connors survey. But there has to be, and I want us to think critically about this, has to be impairment in these symptoms in 2 or more settings. Because, let's think through this. What if this child is an absolute angel in the classroom and is totally out of control at home? And I go back to that uneducated mom who kept setting that little newborn up, and that little newborn kept falling over. That is a household where kids are probably not disciplined in a way, their time is not structured, they're not disciplined in a structured kind of way, where you might see out of control behavior in the home, but that child could be perfectly fine in the classroom, where the teacher's got a nice behavioral program, where kids are reinforced for good behavior, and she's got a timeout program or other kind of token economy where kids get punished for inappropriate behavior. There has to be significant impairment. And some of you a little while ago said that you believe this is underdiagnosed, and I want to speak to that now. We are much better at catching on to this in little boys than we are catching on to this in little girls. Okay. And part of it is because little boys are automatically more physically active. That young testosterone is energizing. Okay. And the little girls got a little less of that young testosterone in their bodies. And so the boys are more likely to create behavioral problems that get noticed. Little girls who tend to be better at being able to control their behavior, they've got a little less of that natural energy. A lot of times they're sitting there not paying attention, not learning. A lot of times the conclusion is they're not that smart, okay? But they've got an attention deficit, but they're not creating behavior problems, okay? Another place where oftentimes we have difficulty with this, again, this is why you got to get them into the psychologist for the testing, is really smart kids with ADHD can oftentimes compensate. Okay. But the problem can be, and I've seen this happen at times with my guys. And I remember being bored to death in school at times. And I used to play a game of how long I could hold my breath with the second hand on the clock just to try to keep myself quiet. That if you've got individuals who are getting through their schoolwork and then they're bored was a bad formula for my sons, okay? Because as soon as they were bored, they were acting up and entertaining themselves. And I remember I used to get into trouble for doing the exact kind of same thing. So we've got to be careful about that kind of stuff. And again, the psychologist is going to test for all of that. And on that note, I'm going to call it a day for today. I just got a text message. We might know who our president is now. I'm going to call it a day for day. We're going to have a short and sweet lecture on Tuesday for your next class. And then you have your third exam. So let me stop my share here. What questions do you have on these childhood disorders or specifically ADHD at this point? Anybody? All righty. I'm going to say goodbye. If anybody's going to come visit me during office hours, I'll see some of you later. I know I've got a bunch of appointments scheduled. Good to see everyone. Y'all take care.